I want to, we've been ignoring our surgeons here, and I wanted to include them in sort of one or two last topics because it's very important to immune therapy. So one of the things that we've noticed in treating, and actually one of the reasons why I believe the combination of ipilimumab and nivolumab is so active is not that the objective response rate is higher, but that we see a higher rate of unconventional responses. So people that have a fair amount of tumor regress, but perhaps one discordant lesion that grows. And that brings up the whole topic of the role of surgery in metastatic melanoma as almost as an adjuvant to immune therapy for metastatic disease. And I wanted to hear your opinions of your role of surgery in this setting.
Yeah, so I think that, fortunately now we have better systemic therapy as we've talked about. But I think that we have to go back and sort of look at, ask the question about surgery in a metastatic setting with metastasectomies. What is the role of surgery, but also what is the response of surgery? And we do know from randomized studies done before we had all of these new agents that in select patients that have resectable metastatic disease, stage 4 patients, that the 5-year survival for those patients can be 40%. And I think we still have to think about that in patients that have oligometastatic disease, which is just a single metastasis. What has changed, though, I think that what is the challenge many times when we have that patients that we now scan and we find that they have a single lesion, we don't necessarily know what the biology of that disease will be. Will those patients progress rapidly, or will they take a longer time to progress? So I think what has changed, though, is that many times now those patients do get systemic therapy. But if we then treat them and they have a partial response but not a complete response, and we've had the time to see what their biology is, I think that surgery does have a role if we can resect those patients at that time. So I think that's one set of patients in metastatic disease that we should consider surgery for. The other patient is, as you pointed out, Mario, is the patients that have now been on treatment and have a mixed response, that they may have they're responding in all lesions with the exception of one lesion. And I do think that in those patients also, if that can be resected with minimal morbidity for the patient, surgery does have a role to resect that. I think the other role of surgery in patients with advanced disease is in patients that respond well, especially to targeted therapies, that they have a tremendous response, but then have some small amount of residual disease. I think in those patients also surgery has a role in and treating them really with that targeted therapy in a neoadjuvant setting to minimize the disease burden and then have them undergo surgery. So I think that surgery in the future, I think will actually in these metastatic patients will probably have even more of a role than it traditionally has had.
I think those are all great points, and I'd even add one additional one. The patients who are on targeted therapy occasionally progress with isolated progressions. And I think those patients are also really candidates for resection. First, I think it gives you, it can provide a more durable response. The patient can remain on drug, and most of their other disease is still sensitive. The other thing is we, with the targeted therapy, at least with single agent targeted therapy, we don't know for sure that progressing lesion is melanoma. And I think it's important in those cases to verify that those patients are not developing a second malignancy due to a paradoxical activation of the pathway. So I think all of those settings.
I do want to make the one point that you made, and we went over it. The neoadjuvant approach now is so important for us with these therapies in order to understand biomarkers and predictors for response. In the metastatic setting, it is very helpful to have that patient who is resectable where you can give a therapy in a neoadjuvant fashion and then take them to surgery like the group at Pittsburgh has been doing to try and find out why certain tumors respond, what are the predictors that we can use in crafting our future trials or identifying the right patients for these treatments.
Yeah. So, and I agree, Omid, I think this is very important. And Mari, you made a small point earlier in our discussion here. You said you talked about in an adjuvant setting, leaving some tumor behind, so to have the immune system be able to respond to that tumor. Do you want to comment some more on that, Mary? Because that really is what we're talking about here, is that using this really kind of a neoadjuvant setting.
It wasn't necessarily leaving tumor behind, but I am concerned that taking out regional nodes, which may be involved in the, I guess, immune surveillance of melanomas, when they come out, that might actually have the opposite effect of what we want. And I think the MSLT2 trial might be very interesting, because we may get opposite of the results that we might expect. It may be that those who have completion lymph node dissections may do worse than those that did not. And actually, I've seen data, I think retrospective data from one institution, which suggested, again, retrospective data, that completion lymph node dissection patients, actually the curve was going in the opposite direction of the ones who did not choose a completion lymph node dissection after sentinel node biopsy. So I don't know the right answer, but that's why we do clinical trials.
But I think that I think it still is important to recognize, though, that currently the treatment for patients with metastatic lymph node disease is a complete node dissection.
No question. The standard of treatment, that's correct. But it'll be very interesting to see the results of this trial. Let me just stop.